So, yeah, so I grew up in Illinois for my first 18 years, and then right prior to my experience here, I was living in San Francisco, working at the Gap in inventory strategy. So, although I didn't have direct exposure or experience in handling pharmaceuticals or medical commodities, I did have experience in supply chain, a very large, extensive supply chain at the Gap. And surprisingly, or maybe not surprisingly, a lot of the issues we dealt with at Gap are similar to the issues we deal with here with data management, kind of changing the mindset, empowering individuals to making decisions. So I've been in Tanzania / Zanzibar for 9 months, coming up on 9 months in a week. And I've worked there with the Ministry of Health and Social Welfare and the Central Medical Store, strengthening our supply chain operations from the bottom up as well as the top down, procurement operations, internal operations within the Central Medical Store. And from there, we've designed a pilot to kind of transition off of their old push system for all their essential medicines to more of a pull system to understand facility requirements and do more demand planning and improve things all the way from the ground in the facility all the way through procurement, one step at a time. It's one of the challenges, or one of the things that's happened is that some programs have by design a pull system, but they've kind of re-engineered it to push to align with the bulk of what's being distributed. So if we figure that if we decide to shift that bulk essential medicines, the other programs will naturally fall into it and design it similar. This paper-based system, the capacity for electronic systems we're still growing. The thought of an SMS-based system is out there, but at this point, as a first step, we just want to get something moving. It's kind of slow, and we're okay with using a paper system. I think the whole point of this project is to empower the facilities regardless of where they are. Even on Ameet, there's so many differences. There's clinics, first line or second line clinics that are known for their maternal services, and other ones that are known more for their malaria services or dental services. So just making sure that they're equipped and empowered to make those decisions on what kind of supplies they need to render the services that they need to render for people. And the same goes in Pemba. Their health requirements are very different than the requirements in Abuja by facility and specifics, but the design of what we're trying to do is really be very specific and targeted to what facilities need. Zanzibar is great. There's a huge opportunity. It tries, offer me an opportunity to be very independent. They haven't really had supply. They've had a supply chain program that they're very well known, and the work they've done with the price of ARVs. And recently, with their shift from HIV and AIDS to general health access, this supply chain program really fits in nicely with that, because we're addressing the supply chain completely, not with just HIV and AIDS, but with all medical commodities. So the opportunity here is huge, and to start, working on developing a pilot, to starting a new program with CHI, with some of the other donors. It's been a fantastic opportunity, and it's been a challenge, but it's been very eye-opening to see.